Good afternoon, ladies and gentlemen. It's a pleasure and honor to be here and to have been asked to report on the work in progress that is being generated by the EHTG, which is the European Hereditary Tumor Group, and the society, and our society, and importantly with tremendous support from the society and financial support also. So let me briefly say what the European Hereditary Tumor Group is. This has evolved from the Mallorca Group that some of you may know. The group has specifically issued guidelines before, and for Lynch syndrome, the first one's in 2007 and the second one's in 2013. And for many reasons that I would like to show you, we think that we cannot defer from informing you and our patients about a change of paradigm in this disease. I have no conflict of interest. So first of all, the rate of hereditary colorectal cancer is grossly underestimated. So if you do panel testing or gene testing in unselected colorectal cancers, you will find that in 12% of these, there is a deleterious mutation. Now, these are not all Lynch syndrome, but it's a very high percentage. Most of them are autosomal dominant. Characteristic for all of them is a high rate of syn and metachronous colorectal and other cancers, which makes the entire topic very interdisciplinary and a little bit complicated. So you have to really take it syndrome by syndrome. We have grossly underestimated also the epigenetic factors. So there is it's not a deleterious gene, and you by necessity get a cancer at a certain age. So this can be influenced by the person, actually by the lifestyle factors and other things. And of course, in this context, prophylactic surgery is of major interest. And all of this is actually really about individualized risk assessment. So you may be aware of the Amsterdam criteria that have been around for quite a long time. I'm not going to go into them. Bottom line is very limited sensitivity and specificity. The Bethesda-Criteria that actually have been misunderstood, they are criteria that indicate that you should do testing for microsatellite instability, also very limited sensitivity and specificity. So that's why we are really seeing a shift of paradigms. I mean, our criteria are not good. We're not finding what we are supposed to find, or not in the extent that we should find it. And so we must question, is our selection criteria based on family history still adequate? Do we have phenotypic selection criteria that can help? What about the preventative potential? Do we need to find them? Well, just to tell you, Lynch syndrome, the estimate of the incidence of Lynch syndrome in Europe is 2.5 million people. So yes, we do need to look into this. And then of course we need to discuss the strategies for intervention once we have found them. So if we start with the phenotype, which is what we have been doing for centuries actually. So if I show this picture to you and tell you that what you see, these polyps are adenomas, then you are righteously gonna say, well that's familial polyposis, that's FAP. You might be right, you might not be right, because, you know, a few less adenomas, some of them serrated, some of them hyperplastic, juvenile hematomas. And, you know, if you start doing gene testing on this, on the same phenotype, you will come up with a lot of different things. It could be a PPAP polyposis, it could be the recessive MUT-YH associated polyposis, which we call MAP. A new gene on the block is NAP. We will get to ZAP, believe me. But we also have recessive B allelic of one of the mismatch repair genes, and there are more out there. We have oligopolyposis, multiple adenomas, hyperplastic polyposis, and Lynch syndrome. So essentially, we, in all of these, have a deleterious gene that predisposes to cancer. But we, as clinicians, cannot say what type of a deleterious mutation it is. So obviously we need genetic testing. Now this gets quite complex, and I think it's very important to put these different syndromes into a scene that's helpful for our clinical management. So I guess the big ones on the block are that you have the polyposis and the non-polyposis one. That's the big divider, right? And in the non-polyposis area, you will have the mismatch repair deficient syndromes, and essentially that comes down to Lynch syndrome. So microsatellite unstable tumors, or if you have the other way around, if you have a Lynch syndrome, your tumor, if it is an associated tumor, will show and will demonstrate microsatellite instability. So what are the underlying genes that lead to this? And I'm sorry, I have to actually bother you with this. You need to know that there are 4 genes, and I think the names are hard for us to remember, but we need to talk about MSH2, MLH1, MSH6, and PMS2, and also EpCAM. So actually when we talk about Lynch syndrome patients, or even when we talk to our patients, it's our task now to make them understand you have a Lynch syndrome, but you have an MSH2 Lynch or a PMS2, and what I'm trying to come down to with the guidelines is that these are different diseases. And if you put gender into this equation, then you have 8 different types of Lynch syndrome. So how can we identify Lynch syndrome easily? Well, by doing immunohistochemistry. It's a very cheap procedure. You look at the tumor and you do your staining, and you have a loss of staining in a certain gene. Then you have, depending on the gene again, fairly high probability that this could be Lynch syndrome. But in order to stick the label to the disease, you have to find the gene. But this is a good pre-screening. It's cheap, it's quite efficient, and that's why since February in 2017 in the UK, the NICE recommendations very clearly state that you should offer testing to all people, all unselected colorectal cancer patients, even without an age limit in there. Of course, then you have a cascade to, continue your algorithm. But this strategy in the UK will lead to a very severe increase in the detection of Lynch syndrome patients. But is the timing correct to do this in the tumor? And I would like to show you why I don't think it's correct. So first of all, in our German guidelines, just to show you that guidelines are not guidelines, of course, as you all know, and that's why they need frequent updates. But in Germany, we also have marked up here that you can do this immunohistochemistry in the biopsy. And actually, the results of the immunohistochemistry are even better quality-wise in the biopsy than in the actual tumor specimen. So why is that important? We need to think about different surgical strategies for these patients. And unfortunately, the reality still is that people come with a cancer, and then it's our task to find out, is this a Lynch syndrome or another underlying hereditary disease, right? That's our task, because we might have to do a different type of surgery. But how are we going to talk to the patient about the type of surgery that he needs at the time of a cancer if we do not know what we're talking about? So I think we have a strong case of trying to get our diagnostics at the time of the diagnosis of a cancer, looking into the biopsy and trying to find out what type of a underlying disease we're talking about. So obviously at the time of a cancer, you have different options. You have your oncological resection that you can do, but in the case of a very high risk profile, perhaps metachronous, a high rate of metachronous cancers, you might want to discuss with the patient if the patient wants to lose more of the target organ at this time. You're not doing a very big extension of your surgery. As we all know as surgeons, it's about one anastomosis. That's the bigger problem. If you resect more or less of the colon, it's not going to be a real time issue. So it's about the anastomosis, and there is no evidence in the literature that we will do more harm by doing this procedure. So the other question is, what about quality of life? Well, again, we are talking the situation of a patient with Lynch syndrome at the time of a cancer. So let's say you have a right-sided cancer. You can do your oncological resection, and this is what you will find in the literature. Everybody will say, well, you can also do an ileorectal, or in the Anglo-American countries, that's the procedure of choice. That's what they tell the patient you've got to do, if you know it's a Lynch syndrome. But we could also talk about doing a little bit limited resection and doing ileosigmoidal anastomosis. Now, there's no data out there to support this, but by doing this, as we all know, certainly this patient will have less bowel movements than if we really do an ileorectal. So these are some of the things we need to talk about. So rectal cancer in Lynch syndrome has also been underestimated. Many of you know Henry Lynch always said, well, that's a right-sided predominance. Well, yes, it is, but we also see a lot of primary rectal cancers. And what do we do about that? So there is some literature around. The problem is really that if you look into the literature of Lynch syndrome, you will always find the expression colorectal cancer. So that's another thing we really need to refine. But we do know that rectal cancer is frequent. We also know that if you have a primary rectal cancer, similar to the colon with your metachronous colon cancer risk, you have a high risk of developing a colon cancer. Especially the younger you are, the more probable it gets. So there is a case for discussing extended surgery at the time of a primary rectal cancer, and especially like in this paper from New Zealand, where they really went into trying to calculate the difference it makes if you remove 10 centimeters more or less of the colon and the risk. So they came up with very high rates of metachronous colon cancer at the time of a primary rectal cancer. So if we are talking extended surgery at the time of a primary rectal cancer, we are talking about a proctocolectomy and an alveolar pouch, which is, of course, major surgery. Okay, so with this background, let me show you what our guidelines are kind of like trying to generate out of the information that we have, the published information, of course. It really is about refining this. So you will see here, you have your different genes, as I have showed you, and then we put gender to add to this, and then we try to see what are the differences, are they relevant, are they statistically relevant enough to modify the guidelines and refine them. But there is a lack of data out there, actually. Like you will see here, if the question is the cumulative incidence, that is risk, of colon cancer at the age of 70 years under regular endoscopic surveillance, that's important. So the data out there is frequently and increasingly more accurate because it's prospective data, but we might not have the difference of males and females like in this case. So we need to go with what we have, since this is work in progress. Same thing for rectal cancer. We cannot distinguish between males and females at this point with their risk. So, for example, if we ask the question, should extended surgery for Lynch syndrome at the time of a colon cancer be performed, the recommendation will be something like extended surgery for primary colon cancer of MLH1 and MSH2 carriers is recommended in order to reduce the risk of subsequent colorectal cancer, although it has not been shown to improve survival. This is important. And there is no evidence out there to suggest this for patients with MSH6 and PMS2. Or, again, to the extent, should we do an ileorectal or ileosigmoidal? We cannot answer this question because it has not been addressed in studies at all. So at this point, it's a personal decision that we should discuss with the patients. Other questions that we ask, or again, a summary of this, the extent of resection for colon cancer would come up with what I've showed you to be this. But there are additional risk factors that we might have to add to the equation, like if there's adenoma formation in a certain segment of the colon, does this influence our decision? And we need to take age into account. So here you see the elderly. We had a meeting this morning, a face-to-face meeting with the committee, and we agreed on also including the younger you are, the more you should be driven to considering more extended surgery, because the risk, of course, of developing a metachronous cancer is higher. So, subtotal colectomy at the time of a colorectal cancer with ileorectal or ileosigmoidal. If we have a rectal cancer as the first cancer, we need to discuss if we really think extended surgery is an option. We do think it is in the guideline committee, but again, we need to differentiate between the different genes. So obviously, at the time of a rectal cancer in the lower penetrant genes like MSH6 and PMS2, this would not be a recommendation. Quality of life is very important, and if we are talking about rectal cancer and extended surgery as an ileoanal pouch, please keep in mind that the quality of life and the functional results need to be compared to the polyposis patients and not to the patients with ulcerative colitis that fare a lot worse, as we all know, than the polyposis patients. So, again, the factors, all of this needs to be factored in. It is work in progress, and it is always an individual decision. We are basing a lot of these recommendations on the excellent data that has been generated by the prospective Lynch syndrome database, which you may find as an interactive tool here. At this point, just to focus your attention, you can put in different variables. It's a very, very neat tool. And if we say we are looking now at a patient, we're interested in the risk of colorectal cancer. This patient has not had any previous cancer, which is an important risk factor, has the age of 40 years, and is male, and we're looking at the gene MLH1. So keep the slope in mind, and the thing we will change in the next picture is gender. So for female, you can see the risk is much lower. Or if we look at the other genes, now it's MSH6, you will see it is even lower, and if we go to PMS2, you will see there's actually no increased cancer risk. So we cannot keep this information from our patients anymore, although we are a little bit insecure and we have to phrase this with serious caution. So because all of this is so complicated, we are now focusing for the first time on doing organ-specific guidelines, and that's the attraction of doing this with the ESCP, of course. So we're focusing on the risk assessment for colorectal cancer and are looking at these parameters. Again, we need to factor this in. We will only briefly, in these guidelines, discuss the role of offering prophylactic hysterectomy or oophorectomy and hysterectomy to female patients that have finalized their family planning at the time of a colorectal cancer. But other than that, we will really focus on this organ and do other organs with other societies. So it's about gene and gender, site and age, and for us, really importantly, colon versus rectal cancer. All of this is risk assessment and trying to tell our patients how high their risk is going to be so that they have a basis to make their own informed decision. Angelina Jolie, as you all know, had a very high risk for breast cancer. It was numbered to be 87%, and for her, that was a high enough risk to make her personal decision of having a prophylactic mastectomy. And that's what we kind of need to do. We're behind the guys with the BRCA mutations, but we are getting a little bit closer, and it's timely to do gene and gender recommendations. And with that, I would like to thank you for your attention, and I'm ready to take questions. Thank you.